Bismillahirrahmanirrahim. Dear students, today we are going to discuss the lipid lowering agents, or it's also called anti-hyperlipidemic drugs. By the end of this chapter or this lecture, you will be able to recognize the structure and metabolism of plasma protein, differentiate between the exogenous and endogenous pathway of lipoproteins. We'll be discussing the different classes of anti-hyperlipidemic drugs, and along with that, you will have to know the mechanism, the role of different lipid lowering drugs in clinical practice, and list the major side effects and drug interaction of these lipid lowering drugs. So where the lipids is coming to the blood, or from where the lipids come to the blood. So there are two pathways. Endogenous lipids is synthesized within the liver, and exogenous lipids can be absorbed from the intestine. So the drugs, they can either inhibit the endogenous biosynthesis of lipids within the liver, or can decrease the absorption of these lipids from the intestine. So we will have two types of drug, or two main classes of drug. One of them that will decrease the biosynthesis of liver with the biosynthesis of lipids from the liver. The other will inhibit the absorption of these lipids from the intestine. So this is almost the same diagram as the previous one, with a little bit more details that the lipids are absorbed in the form of chylomicron from the intestine, which circulate in the blood and goes to the liver through enterohepatic circulation. And the liver again form the very low density lipoprotein from this low density lipoproteins LDL. So here we have to note the drugs can act here, decreasing the absorption of the lipids, or it can decrease the synthesis of this very low density lipoprotein from the liver. Here we can see that lipoprotein lipase causes the absorption of lipids from the blood into the fatty tissues. So some drug can act here. They increases the activity of lipoprotein lipase and increases the absorption of lipids from the blood into the fatty tissues. While some can increases the absorption of this low density lipoprotein into the extrahepatic tissue. So all these drugs we will study in details in the coming slides. So here we will discuss a little bit about the types of lipoproteins. You might have discussed this in your biochemistry or the details, but here we will only discuss their origin. Like chylomicron is absorbed from the intestine, the source is intestine, while the liver can secrete the very low density lipoproteins, and low density lipoprotein blood from the chylomicrons, and very low density protein very low density lipoproteins, they are converted to low density lipoprotein within the blood. Liver can also synthesize this HDL, high density lipoprotein. So if you can see, these are the bad cholesterol, they are harmful, while this HDL, if this is known as good cholesterol. So it is inversely proportional to the hyperlipidemia, while this is directly proportional to the hyperlipidemia. So basically, hyperlipidemia is the elevated level of very low density lipoproteins or bad cholesterol. As you have seen, very low density lipoproteins or LDL, low density lipoproteins, or chylomicrons, these are all bad cholesterol. And elevated concentration of these lipids can lead to the development of atherosclerosis and coronary artery diseases. So what happens there that it decreases it causes the narrowing down of the blood vessels and can lead to the blockade or the blockade of the blood flow. So very low density lipoproteins and LDLs, low density lipoproteins, are atherogenic lipoproteins, whereas HDL concentration are inversely related to the incidence of coronary artery diseases. This is considered to be as a good cholesterol. Hence, the treatment for hyperlipidemia aims to reduce the LDL level and raise the HDL level. Now, hyperlipidemia can be of two types, like hypertension. It can be primary or secondary. Secondary is related to a disease, and that can lead to the development of hyperlipidemia. But primary have a genetic predisposition, and they cannot be treated, but we can maintain it or manage it. Like example is familial hypercholesterolemia, where there is a defect in the LDL receptors on the extrahepatic tissue. So the low density lipoproteins cannot be endocytosed by the tissues. It will remain in the blood, and that can lead to hyperlipidemia. Secondary causes of hyperlipidemia, these are the different diseases or conditions which can lead to this hyperlipidemia, like diabetes mellitus, nephrotic syndrome, alcohol use, contraceptive use, and estrogen use, glucocorticoids, hypothyroidism, obstructive liver disease. These are the conditions which can lead to hyperlipidemia. Guidelines for the adult treatment. These are the different values: desirable or borderline, to high and high. So these are the desirable values for the hyperlipidemia, that the total cholesterol should be less than 200 millimole per liter in the blood. Low density lipoprotein cholesterol should be less than 130. Uh, and for men, the HDL should be more than 40 for men and more than 50 for females, while triglycerides should be less than 120. You don't have to memorize these numbers. We normally don't ask for these numbers. It's only just for your understanding. So no need for memorizing these numbers. So these are the drugs which we will be discussing in this chapter: statins, fibrates, nicotinic acid, cholesterol absorption inhibitor, bile acid binding resins, omega-3 fatty acid. We will discuss their mechanism, their effects, side effects, and drug interaction. So the first line drug for the treatment of hyperlipidemia are the statins. They are also called HMG coenzyme A reductase inhibitors, because they inhibit the enzyme which is responsible for the formation of cholesterol. So these drugs inhibit the first step in the synthesis of cholesterol, and cholesterol, that is important for the synthesis of very low density lipoproteins. So it indirectly inhibiting the formation of very low density lipoproteins. And the second effect is that when it inhibits the formation of cholesterol, so the cell become deficient of cholesterol, and it want to absorb more LDL from the blood. So it causes the upregulation of LDL receptor in order to absorb more lipids for the formation of cholesterol. So it has a dual action, inhibiting the formation of very low density lipoprotein, and on the other hand, it can upregulate the formation of LDL receptor, which in turn internalize more LDL to the cells and decreases the hyperlipidemia with low density lipoprotein within the blood. The example of these drugs are levetiracetam, simvastatin. So all these drugs have this statin. That's why they are called statins. They are the most effective in reducing the LDL level from in the blood. A mechanisms that we have described in the table or diagrams, that these drugs are competitive inhibitor of the enzyme 3 hydroxy 3 methyl coenzyme A reductase, or it is also called HMG. So H is hydroxy methyl glutaryl coenzyme A reductase, which is the rate limiting step in the biosynthesis of cholesterol. These are short-acting statins such as levostatin, pravastatins, and simvastatins are given at the night to reduce the peak cholesterol biosynthesis in the early morning. These drugs can produce side effects like hepatotoxicity or causing the muscle wasting, that is called myopathy. So that's why serum transaminase enzyme has to be regularly periodically checked in order to see the function of a liver, because these enzymes are the basically diagnostic marker for the function of liver, while a creatinine kinase is the increases creatinine level, and that can lead to myopathy. This drug can affect the function of the liver. That's why these serum transaminase enzyme has to be regularly monitored in order to see the function of liver. Well, in some people it can also affect the muscles, and it causes muscle wasting. But that case is rarely. So hepatotoxicity is one of the main side effects of these drugs because of the biochemical abnormalities in the liver function. So that's why serum transaminase enzyme has to be regularly monitored in order to see the effect of the function of the liver. It can also lead to myopathy or muscle wasting. However, this effect is rare and it can be increased when this drug is combined with other anti-hyperlipidemic drugs like Fibrates or Niacin. So that's why creatine kinase activity and serum transaminase enzymes, this has to be periodically checked in order to see the function of liver and in order to see the muscle wasting. It can also cause GIT upset or headache. Cytochrome 3,4-A inhibitors, macrolides, antibiotics, ketoconazole, verapamil also causes and increase the risk of myopathy. So because these drugs will inhibit the metabolism of statin, so it will lead to more bioaccumulation of statin and it will increase the risk of myopathy. These drugs are contraindicated in pregnancy and nursing mothers, so because they can cross the placenta and can excrete through the milk and can reach the fetus who are feeding their mothers, who are feeding by their mothers. The second class in this group or in this category is the fibric acid derivatives. They are also called fibrates because these drugs are ended with fibrate, fenofibrate, clofibrate, or benzofibrate. All these are fibric acid derivatives. What they basically do, they bind to the PPA or A receptors in the liver, heart, kidney, and skeletal muscles and increases or modulate the fat metabolism. So on the one hand, they increases the absorption of fat into these organs, and then these are metabolized in these organs. On the other hand, it also increases the lipoprotein lipase activity and causes the reabsorption of fatty acid into the adipose tissue. So that's how it can decreases the level of cholesterol in the blood. Normally, these drugs lower the very low density lipoproteins by 40% and the LDL level by the 10%. So it can be used for the hypercholesterolemia, while it can increases the HDL level by 10%. Most of the effects, common side effects, is dyspepsia. Myopathy is very less common. However, it can increase when it is combined with the statins. Increase hepatic enzyme. It can increase the enzymes of the liver, and that can increase the metabolism of certain drugs. However, with anticoagulants, it can displace the protein binding of the anticoagulants like coumarin, so that will lead to more free form of the anticoagulant in the blood and will increase the anticoagulant effect of these anticoagulants. It can also decreases the metabolism of sulfonylureas, which is an hypoglycemic drug. So it can also increases the effect of the hypoglycemic drug and can lead to hypoglycemia. So nicotinic acid or niacins, they inhibit the lipolysis, and by inhibiting the lipolysis they are inhibiting the formation of fatty acids, and this decreases the availability of fatty acid for the formation of triglyceride and VLDL, very low density lipoprotein, in the liver. So here it decreases the production of very low density lipoprotein by the liver. These are normally given in gram doses from 1 to 6 milligram. And nicotinic, it also decreases the formation and secretion of very low density lipoprotein by the liver. This is an interesting response, that it can decreases or shift the LDL particles to larger size, and larger LDL protein are considered to be less atherogenic as compared to the low density lipo. So there are a number of studies which shows this data, that low density lipoproteins are more atherogenic as compared to very low density lipoprotein. It can also increase the plasma HDL level. It's the most potent drug for increasing the HDL level. Adverse effects, pruritus or flushing. This is the main side effects, one of the main, and it can be decreased by the prostaglandin synthesis inhibitor like aspirin. So the niacin flush results from the stimulation of prostaglandin, and this flush is avoided by low doses of aspirin, by a low dose around 325 milligram. So this will inhibit the COX-2 enzyme as well, because this is the lower dose used for inhibition of the prostaglandin, for the inhibition of cyclooxygenase 2 enzyme. So normally this aspirin is given half hour before the niacin in order to avoid this flushing or pruritus. Hepatotoxicity, most common with all these drugs. Reactivation of peptic ulcer, because it stimulates histamine release, resulting from increased gastric motility and acid production. So it is also one of the main side effects. Hyperglycemia and increased uric acid level. Hyperglycemia is because of it can impair glucose tolerance, and it can decreases the excretion of the uric acid from the it can increase the excretion of uric acid, which leads to increased uric acid level in the blood. So these are the most common side effects of this drug. Now the fourth class in this series is the cholesterol absorption inhibitors. Basically, they inhibit the absorption of lipids from the intestine. So they mainly work in the intestine. Uh, Ezetimibe is the main drug in this class, which decreases the intestinal absorption of phytosterol and cholesterol. Its primary clinical effect is reduction of low-density lipoprotein. Mechanisms that selectively uh, inhibit the intestinal absorption of cholesterol and phytosterols. So they are mainly affecting here in the GIT, and their side effect is also related mostly to the GIT, like constipation or GIT complaints like heartburn, dyspepsia, flatulence. These are their side effects mainly associated to GIT. Bile acid binding resins, it also work in the GIT, and their function is to inhibit the reabsorption of these bile acids, which are secreted by the liver into the small intestine, and normally they are reabsorbed back through enterohepatic circulation. So these drugs inhibit the bile acid reabsorption into the liver and excrete these bile acid. So since these bile acids are required for intestinal absorption of cholesterol, so we are inhibiting the absorption of cholesterol from the GIT. And this also results in increased use of cholesterol to replace the excreted bile acid and lowering of hepatic cholesterol. So these are the effect of bile acid resins, and their side effects is related to the GIT, mainly heartburn, flatulence, or dyspepsia. However, they also impair the absorption of fat-soluble vitamins like A, D, E, and K. And if you see if this vitamin K play a significant role in the blood clotting, so this vitamin deficiency can lead to increased bleeding tendency, because that's as we have seen in the anticoagulant drug, that vitamin K reductase is responsible for the formation of different coagulation factors. So that vitamin K deficiency leads to more bleeding because it decreases the coagulation of blood. The last class in this is omega-3 fatty acids. It's a diet rich in omega-3 fatty acid from the oily fish decreases the triglyceride concentration, but increases the cholesterol. So it can also be used for decreasing the hyperlipidemia. Eating fish regularly decreases ischemic heart disease because it can contain these omega-3 fatty acids. So to summarize, for the management of these chronic diseases, the first step is to modify the lifestyle. If we cannot control it, then we can go for drugs. And the two main categories of drug, one was the inhibition of the endogenous lipids, and in this category we have discussed the statins, fibrates, nicotinic acid, which are targeting the endogenous lipid production, while the second category is the drugs which are inhibiting the reabsorption of cholesterol from the GIT or from the intestine. So these are the drugs which we have discussed in this class. If you have any questions, you can ask me anytime. Thank you.